สร้างเศรษฐกิจคนเศรษฐศาสตร์โดยคณะเศรษฐศาสตร์จุฬาลงกรณ์มหาวิทยาลัย
This is CU Radio, hosted by the Faculty of Economics at Chulalongkorn University. Hello, my name is Chantal Herberholz, and today I'm going to talk about my forthcoming book on financing healthcare for migrants, refugees, and stateless persons. Migration is one of the defining issues of the 21st century. According to the World Migration Report, there were about 280 million international migrants in 2020. Due to recent refugee crises related to conflict and war, there were about 89 million people living in displacement. Large migration flows and stocks pose huge challenges for countries of origin, transit, and receiving countries, especially also for their health systems. Therefore, countries have increasingly tried to address migrant health and healthcare access in their national health policies. Moreover, health and migration are both key aspects of sustainable development and explicitly recognized in the Sustainable Development Goals. The 2030 Agenda for Sustainable Development is actually based on the principle of leaving no one behind, and therefore it focuses on vulnerable and marginalized groups, including migrants. The COVID-19 pandemic has exacerbated the most persistent causes of health inequalities and further highlighted existing gaps in health coverage. My book provides an analysis of public healthcare financing schemes for migrants in 8 Western European and 3 Southeast Asian countries in the era of COVID-19. The information for my book was largely obtained from a comprehensive review of the literature. Today, I will focus on only 3 of the 11 countries. So that is, I will talk about the 3 Southeast Asian countries, Malaysia, Thailand, and Singapore. Moreover, I will focus on economic migrants, refugees, and stateless persons. Let me define these terms a little bit. The term migrant itself is actually quite ambiguous. There is no universal definition at the international level. It generally refers to a person who moves away from the usual place of residence, either within a country or across an international border, temporarily or permanently, and for different reasons. There are many subcategories. For example, we normally distinguish documented from undocumented migrants. Documented migrants, in contrast to undocumented migrants, possess the necessary paperwork and have obtained a permission to stay in the destination country. We can also distinguish different migrant groups based on the reason for migration. So for instance, one large group are economic migrants. So these are migrants that have moved for economic reasons. Refugees are very distinct from other migrant groups. Refugees refers to people who have fled war, violence, conflict, or persecution, and have crossed an international border to find safety. Their status is determined. As long as the status is determined, they are referred to as asylum seekers. Stateless persons, on the other hand, according to the 1954 Convention relating to the status of stateless persons, are persons who are not considered as a national by any state under the operation of its law. So let me focus today on documented migrant workers, refugees, and stateless persons. Now, the distinction based on the legal status is important because based on this status, there are different entitlements to healthcare. Let me now explain these entitlements, starting first with Malaysia and Singapore, and then moving on to Thailand. Now, migrant workers under temporary labor migration programs or contracts are basically insured under private insurance contracts in both Malaysia and Singapore. In Malaysia, there is a foreign worker hospitalization and surgical insurance scheme, which is mandatory for documented foreign workers, with the exception of domestic and plantation workers. This scheme, which is managed by the Ministry of Health, provides coverage for inpatient care, but not for outpatient services. The coverage is restricted to the annual insurance limit, and any bills in excess of that limit have to be paid out of pocket. Ultimately, the employer is responsible. The insurance premium for this coverage has to be paid by the employer and/or the employee. So this indicates that under the scheme, the ultimate responsibility for migrant workers is vested in the employer. So if some medical bills are not paid, then this has implications for work permit renewal. It is also important to point out that in Malaysia, non-citizens are subject to higher medical fees. So that is, with a very limited insurance coverage, they are likely to have to pay out of pocket. Now, in Singapore, the ultimate responsibility for temporary labor migrants is also vested in employers. Employers are required to purchase private medical insurance for inpatient care, and this is also subject to an annual insurance limit. So there's also balanced billing. So that is, if the actual medical expenses exceed the annual limit, then the excess has to be paid by the employer. Similar like in Malaysia, insurance premiums have to be paid for this coverage. So again, the key point here is that the focus is on temporary labor migration programs and contracts, and that migrant workers are covered by private insurance contracts, and that the ultimate responsibility is vested in the employers. This is quite different from the approach used in Thailand. Documented migrant workers in the formal sector are covered by the Social Security scheme, like nationals. So in return for making the Social Security contributions, documented migrant workers under the Social Security scheme are covered by a comprehensive benefit package. Now, the situation is different for those migrants who are not covered by the Social Security scheme. So this refers mainly to migrant workers in the informal sector. These migrant workers have to purchase the migrant health insurance that's offered by the Ministry of Public Health. This migrant health insurance offers a comprehensive benefit package, and in return, migrants have to pay an insurance premium. There is a separate package for migrant children, so that is children below the age of 7. It also offers a comprehensive benefit package, and migrants have to pay insurance premiums. Now, the premium for the migrant health insurance for children is relatively low, currently priced at 1 baht per day. The situation is very different for refugees and asylum seekers in all 3 countries. In all 3 Southeast Asian countries, there is no national legal framework to address issues related to refugees. So in that sense, in the 3 countries, refugees and asylum seekers depend on current government policies that can change at any time and case-by-case decisions. Now, let me start with Malaysia. In Malaysia, given that there is no legal framework regarding refugees and asylum seekers, these are essentially considered illegal. However, they are tolerated if they are registered and supported by international organizations, such as UNHCR, that means the United Nations High Commissioner for Refugees. The situation is similar in Singapore, where decisions are made on a case-by-case decision. Also in Thailand, refugees and asylum seekers are not formally recognized in the absence of a legal framework, so they depend on current government policies. And typically a distinction is made between refugees who are residing in temporary shelters along the Thai-Myanmar border and those living in urban areas. In any case, for both groups, in terms of entitlement to healthcare, they depend entirely, or largely, I should say, on humanitarian assistance. For stateless persons, on the other hand, their situation, and here I mean in terms of the entitlement to healthcare access, depends on their status in Malaysia. So that means those who are registered with UNHCR, they can access healthcare services, and as UNHCR card holders, they are also eligible to receive a discount. Like, for example, other migrant groups, most notably refugees and asylum seekers. Now, in Singapore, there's actually a large number of stateless persons who are permanent residents. Permanent residents in Singapore and Malaysia can receive healthcare under public schemes. However, in Singapore, not on the same basis as nationals. For stateless persons who hold a special pass, who have a permission to be in Singapore, they can also access healthcare on a fee-paying basis. But for other stateless persons in Singapore, they would be considered undocumented migrants and thereby illegal. Now, in Thailand, the situation again is a bit different, because in Thailand, there's actually a health insurance for people with citizenship problems that was set up in 2010 for defined stateless populations who are registered in Thailand's civil registry. The health insurance for people with citizenship problems offers a comprehensive benefit package, and it is paid out of general taxes. However, those who are not covered by this scheme, they depend on humanitarian assistance. Now, despite these entitlements, there are many barriers to accessing healthcare. So in Malaysia, for example, the special insurance scheme that's set up by the Ministry of Health for documented migrant workers is not governed by law. So therefore, there are problems with non-compliance with the health insurance mandate in the absence of a legal basis. Also, as I said before, there are coverage gaps. So for example, plantation and domestic workers are not covered. Other access barriers arise because in Malaysia, there are communication problems. So research has shown that migrant workers who are enrolled in the scheme and their employers have insufficient information about the health insurance plan. They do not even receive a health insurance card and therefore are not aware of their entitlements. Also, like I said before, given the high fees in public facilities for non-citizens, the benefit package, which excludes outpatient services, and the annual coverage amounts are considered to be inadequate. And another problem that's common across many countries, including Malaysia, is the fact that there are communication problems between the patients and the providers. Now, in Singapore, barriers are similar. So for instance, as I said before, there's an annual insurance limit on the private health insurance package that migrant workers are required to purchase. And of course, this causes problems if the excess has to be paid out of pocket, so thereby causing financial barriers. Similar to Malaysia, research has shown that migrant workers in Singapore do not seem to have access to information about health insurance benefits and coverage. So despite entitlements, there are many barriers that prevent migrants from accessing healthcare, even if they are entitled. Now, in Thailand, let me start with the migrant health insurance. So those migrants that are covered by the migrant health insurance, that have purchased this insurance package, also face many access barriers. One of the barriers also refers to the communication between patients and providers. So especially if there are language or cultural barriers, this will make it difficult for migrants to actually access healthcare services. Then second, there is, similar to Malaysia, a problem with the enforcement because the migrant health insurance is based on cabinet resolutions. So it lacks a little bit a strong legal basis. In Thailand, initially, when the migrant health insurance was set up, it was constrained by the limited capacity of the unit in charge at the Ministry of Public Health. So therefore, the migrant health insurance had problems with its administration and monitoring. Regarding the health insurance for people with citizenship problems, there are also many access barriers. So especially given that the health insurance for people with citizenship problems is also administered by a unit within the Ministry of Public Health that's capacity is quite limited. Also, some people who are not within the defined stateless target population of the scheme are excluded and therefore are not entitled to healthcare access. This constitutes a major barrier. And like what we have seen about, or in case of Malaysia, there's a lot of confusion about the actual benefits of the health insurance for people with citizenship problems among patients and providers. Yeah, so there seem to be also communication problems between the Ministry of Public Health and the providers. Just to sum up the key barriers, the key access barriers, these basically can be categorized into two groups. So first of all, these barriers that are related to the policy design, and second, barriers that are related to the policy implementation. In terms of policy design, we have seen that there are problems with the legal framework in Malaysia and Thailand. Second, there are problems regarding the population and benefit coverage. So in Malaysia and Singapore, there is a quite limited annual coverage under the private health insurance contract that results in any excess having to be paid out of pocket and creates financial barriers. In Thailand, there's a problem with the management capacity, or at least initially, of the unit within the Ministry of Public Health charged with handling the schemes for migrants and also stateless persons. And also there are administrative processes in terms of migrants having difficulties registering with the respective schemes. So these problems were found to be prevalent in Malaysia and Thailand. Regarding the policy implementation, one of the key problems observed in Thailand based on the literature was that there was a lack of clear guidelines for policy implementation. So there was a lot of uncertainty among providers in Thailand, what exactly the benefit package of either scheme would be and who the target population is. Also, there are a lot of barriers that arise due to communication problems. So here, communication between the patient and the provider. This is something that generally arises in the context of migrant health and migrants' access to healthcare, given that there are usually huge language and cultural barriers. And then, of course, there is generally a problem, as we have seen on the basis of the experience in Malaysia, with being aware of the health insurance coverage. Like in Malaysia, insureds do not even have an insurance card and therefore are largely unaware of their benefits. Now, based on the comprehensive review of the literature, the book identifies a couple of issues that need to be addressed by policymakers. First of all, connecting to the access barriers. Many of these access barriers have been there for a long period of time, and the COVID-19 pandemic has actually exacerbated these barriers. So it is important for policymakers to basically tackle these long-standing access barriers to ensure that those migrants who have entitlements to healthcare can actually access these services. Now, another problem related to the parallel schemes, most notably those for migrant workers in Malaysia, Singapore, and Thailand, in the form of the migrant health insurance, is the issue of having or creating a two-tiered system. So having a main healthcare system for nationals and having a sort of another tier for migrant workers, which can easily turn into a bottom tier within the health system. So one has to generally reflect again how useful it is to have different systems for different types of people. Now, regarding the main schemes, so especially looking at the social security scheme in the context of Thailand, one of the key issues that emerged from the analysis is that migrants face huge problems in terms of the portability of their social security benefits. So migrant workers who are working in Thailand, if they're registered with the social security scheme, they are eligible to receive several benefits. So not only healthcare benefits, but also unemployment benefits, old age benefits, and so on and so forth. Now, the problem is that when they go back to their home country, given that very often we are looking at temporary labor migrants, there is an issue regarding the portability of benefits. It's still very difficult to carry benefits earned under, for instance, a social security program from Thailand to other countries. So it's very difficult generally to maintain and transfer the social security rights across countries. This is not only specific to Southeast Asia, but generally a problem, including still within the European Union. Another key problem that emerged from the analysis is sort of the recognition that even though in Malaysia, Thailand, and Singapore, the focus is on temporary labor migration, still one has to acknowledge that temporary migration very often is a permanent migration. So therefore, many of the arrangements are not suitable for migrants. Yeah? So there needs to be a shift in thinking, perhaps recognizing that nothing is as permanent as temporary migration, and then seeing in how far one can accommodate the needs of those migrants who stay in a destination country for a longer period of time. And then the last point that emerged from the analysis is sort of a recognition that there are definitional issues. So as I said at the beginning, the term migrant is very broad and ambiguous, and there are different migrant groups included under this umbrella term. The legal status matters for healthcare entitlement, and therefore it's particularly important to have disaggregated data so that policymakers have information about the specific migrant groups. Today, I only focused on 3 groups. So that means documented labor migrants, refugees, and stateless persons. However, there are many other migrant subgroups. And to understand their entitlements, lack of entitlements, and barriers better, it's important to have timely disaggregated data. And that's one of the key challenges that policymakers are facing. And having disaggregated data would be very useful to influence and guide their decision-making. So the COVID-19 pandemic has drawn attention to the plight of many migrant workers around the world. And I hope that the COVID-19 pandemic can be an opportunity to ensure that no migrant is left behind in the future. Thank you very much for listening. Bye-bye.